Welcome to the Information Blocking Provider Disincentives Proposed Rule Information session. My name is Tom Deneen with Kaufman and Associates and will be assisting with today's logistical support for the Zoom session. To ask questions, click the Q&A button at the bottom of your screen. However, please note that there are restrictions to what can be answered due to the Administrative Procedure Act. Please use the raise hand function under reactions, and we will unmute your line to verbally ask questions during the Q&A portion of the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present information. If you need technical assistance during the session, please type the issue into the chat box and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Alex Baker.
Great, thank you so much. And thanks to everyone for joining today. We are going to spend some time talking about a new notice of proposed rulemaking, which is entitled 21st Century Cures Act, Establishment of Disincentives for Healthcare Providers that have committed information blocking. And this is a rule that comes from multiple parts of the department, including proposals both that the Office of the National Coordinator for Health Information Technology has made, which is in the Office of the Secretary, and also proposals from the Centers for Medicare and Medicaid, and have a few colleagues on the line from CMS that will describe their proposals in the rule in just a moment. So before we get into the details of this notice of proposed rulemaking, just want to give sort of a 30,000-foot overview about where we are on information blocking. So folks may remember that almost 3 years ago, more than 3 years ago now, ONC put out the first major piece of regulation implementing the information blocking provisions that were in the 21st Century Cures Act. That was called the ONC 21st Century Cures Act Final Rule. And what that rule really did was to set out some of the key terms and definitions around information blocking. So, and folks can look at the ONC website for a lot of resources on that rule, including how information blocking itself is defined, how the different types of actors who are subject to the information blocking regulations are defined, what information should move under the information blocking regulations, as well as reasonable and necessary activities that do not constitute information blocking, which are called exceptions in that final rule, and which include, there are 8 exceptions, including situations where information should move, but there's a reason why it did not, exceptions around how that information is moving, and other things related to whether information is not moving due to privacy and security concerns or issues around preventing harm. So that was the first big piece of policy that came out around information blocking. Just this past summer, OIG put out a new a final rule that focuses on enforcement for a number of the actors that are subject to the information blocking regulations. We'll talk a little bit more about that in a second. And then this proposed rule really focuses on the remainder of enforcement for the remainder of the actors that are subject to the information blocking regulations, which are healthcare providers. So next slide. So just to reiterate some of the disclaimers mentioned previously, this presentation, we've sought to make this presentation accurate and reflect the proposed rule, but this presentation is not a legal document, and the official provisions of this rulemaking are found in the proposed rule. ONC can only present information that is in the proposed rule as it is contained in the rule and cannot interpret information or clarify or provide any further guidance beyond what is in that proposed rule as part of the requirements of the Administrative Procedure Act. And that HHS cannot address any comments made by those attending the presentation or consider such comments in the rulemaking process unless those comments are submitted through the formal submission process as specified in the Federal Register. And with that, we'll go to the next slide. So this proposed rule was published in the Federal Register on November 1st, about 2 weeks ago, and that started the clock for a 60-day public comment period, which means that comments must be received via the Federal Register no later than 11:59 p.m. Eastern Time on January 2nd, 2024. And there is the link that you can use to submit public comments. Next slide. So what is the purpose of this proposed rule? Next slide. So this proposed rule implements the Health and Human Services Secretary's authority under Section 4004 of the 21st Century Cures Act. It establishes disincentives for healthcare providers that commit information blocking as determined through an investigation by OIG. And it complements, as I noted, OIG's rule from this past summer, which established civil money penalties authorized for other actors that have committed information blocking. Next slide. So this is a little more about the background that we discussed in the proposed rule. Next slide. Section 4004 of the Cures Act identified several different types of actors that are subject to the information blocking regulations. That includes health information technology developers, exchanges or networks, and healthcare providers that are all part of the definition of who can commit information blocking. It's important to note that if conducted by a healthcare provider, such provider knows that a practice is unreasonable and is likely to interfere with, prevent, or materially discourage access, exchange, or use of electronic health information. That is a different standard than some of the other actors identified in the definition who must know or should know that a practice is information blocking. So a little bit of a distinction there that it's important to remember. There are also different approaches to enforcement for these different types of actors that are reflected in the two rules that we put out. So for healthcare providers, the Cures Act says that OIG, when they determine a healthcare provider has committed information blocking, they must refer that healthcare provider to the appropriate agency to be subject to appropriate disincentives using authorities under applicable federal law as the Secretary sets forth through notice and comment rulemaking. And that is a different enforcement path than for health information technology developers, exchanges, or networks, where the Cures Act authorized the Secretary to impose civil monetary penalties of up to $1 million per violation on those actors if OIG determines that they've committed information blocking. Next slide. So the proposed rule talks a little bit about who is considered a healthcare provider under the information blocking regulations, and notes that in the 21st Century Cures Act final rule from 2020 that I talked about, ONC adopted the definition of healthcare provider that is found in Section 3000 of the Public Health Service Act within our regulation in order to specify what is meant by healthcare provider. And as you can see, that Public Health Service Act definition includes a wide range of healthcare provider types, perhaps some both hospitals and long-term care facilities, physicians, these kinds of providers, but also providers like laboratories, pharmacies, pharmacists, Indian Health Service operators, et cetera. Next slide. So what proposals does the proposed rule include? Next slide. So the provisions of the proposed rule start with a discussion of the enforcement provision for providers that I read previously, which we call the disincentives provision in the rule. We define a number of terms that are in this provision and also talk about how we are interpreting it, which informs the proposals that we are making for enforcement as part of the proposed rule. So that includes a proposal to define appropriate agency to mean a government agency that has established disincentives for healthcare providers that OIG determines have committed information blocking. Includes a proposal to define the term disincentive to mean a condition that may be imposed by an appropriate agency on a healthcare provider that OIG determines has committed information blocking and is specifically identified in 45 CFR Part 171, so that and states that ONC will list those finalized information blocking disincentives in this section of the Code of Federal Regulations. Another important piece here, we note that the Cures Act does not include any further guidance about what an appropriate disincentive should be, does not provide any further illustration about what that term should mean. And so we state in the proposed rule that we consider a disincentive to be any condition established through notice and comment rulemaking that we determine would deter information blocking practices among healthcare providers that are subject to the information blocking regulations. Next slide. Another important piece here is the phrase authorities under applicable federal law that was used in the Cures Act. And the proposed rule discusses that we propose to interpret this to mean that an appropriate agency may only subject a healthcare provider to a disincentive established using authorities that could apply to information blocking by a healthcare provider subject to the authority, such as healthcare providers participating in a program supported by the authority. And so as you will see, in this rule, we have proposed to use applicable federal law, specifically several authorities under CMS in order to establish these disincentives. Finally, we also note that the Cures Act does not place any limits on disincentives that would be applied to a healthcare provider. And so we clarify that if OIG determines a healthcare provider has committed information blocking and refers them to an appropriate agency, that healthcare provider would be subject to each of the appropriate disincentives that an agency has established through notice and comment rulemaking that is applicable to the healthcare provider. Next slide. So the proposed rule then turns to a section specifically about the OIG investigation and referral process. Important to note that information in the rule regarding OIG's approach is not a regulatory proposal, but is information that OIG has provided for public awareness. Much of this section summarizes elements of the July 2023 OIG final rule. And so if folks want to dig into more of the specifics about OIG's process, would suggest looking at that final rule, which again has only been summarized as part of this proposed rulemaking. However, we do note a couple of areas that are specific to healthcare providers. So for instance, in OIG's final rule, they described anticipated priorities that they would use for enforcement and determining when they will pursue an investigation of information blocking based on claims that they receive. Specifically for healthcare providers, they note that the priorities would be practices that resulted in, are causing, or have the potential to cause patient harm, practices that significantly impacted a provider's ability to care for patients, practices that were of long duration, and practices that caused financial loss to federal healthcare programs or other government or private entities. And there is a request for comment from the public on whether these are an appropriate set of enforcement priorities. The rule also briefly discusses how OIG plans to coordinate with other agencies. For instance, the Cures Act states that if OIG receives a claim of information blocking that it determines could potentially be resolved through HIPAA and patient right of access authorities, that they may work with OCR to resolve a claim in that manner. So this section kind of recaps on some of those issues around coordination. Next slide. So then this section specifically talks about the referral process for a healthcare provider, which again is specific to the healthcare provider case, where the statute says that healthcare providers must be referred to an appropriate agency to be subject to disincentives, and notes that OIG plans that prior to making a referral, it would coordinate with the appropriate agency to which OIG plans to refer its determination of information blocking, that once it hasn't concluded its investigation and is prepared to make a referral, it will send information to the appropriate agency indicating that the referral is made pursuant to the statutory requirement, and then discusses some of the information that OIG would expect to provide to the appropriate agency to which it's making its referral, which could include things like the dates when OIG has determined the information blocking violation or violations occurred, analysis to explain how the evidence demonstrates the healthcare provider committed information blocking, copies of evidence collected during the investigation, and any additional information as part of the referral that they want to provide based on their consultation with the appropriate agency to the extent permitted by law. Next slide. So the proposed rule then turns to a number of general provisions for application of disincentives. So as noted previously, it proposes that these disincentives will be listed in 45 CFR Part 171. It proposes common elements for the notice that an appropriate agency would send to a healthcare provider that is subject to a disincentive or disincentives, and that this notice could include a description of the practice or practices that form the basis for the determination of information blocking, the basis of the application of the disincentive or disincentives being imposed, the effect of each disincentive, and any other information necessary for a healthcare provider to understand how each disincentive will be implemented. And finally, this section notes that another important distinction between how the Cures Act treats enforcement for these different actors. For the developers of certified health IT networks and exchanges, the Cures Act instructed OIG to use appeals procedures that it uses for other civil money penalty cases that it pursues and provides penalties for. The Cures Act did not provide any comparable instruction regarding healthcare providers. And so for healthcare providers, the right to administratively appeal a disincentive would be based on the authority that was used to establish that disincentive and any rights that that authority may offer. Next slide. So finally, in this section, we go into a proposal for transparency for information blocking determinations, disincentives, and penalties. And important to note that these proposed transparency provisions would apply to all actors, not just healthcare providers, which is mainly the focus of this rule, and is an effort to expand on the information that ONC makes available on its website that is intended to help the public understand where information blocking is occurring and how it is impacting the nationwide health information technology infrastructure. And we propose here that we would include on ONC's website information about information blocking determinations by OIG, such as identifying the information blocking practices, identifying actors who committed information blocking, and any settlements of liability, civil money penalties levied, and disincentives administered. So that is the central section of the rule, and the next section goes specifically into the proposals 4 appropriate disincentives that are being proposed under CMS authorities. And so I am going to turn it first to my colleague Elizabeth Holland in the Center for Clinical Standards and Quality, who is going to talk about 2 of the disincentives proposals. Elizabeth, are you on the line?
Yep, thank you, Alex. I'm Elizabeth Holland, as he mentioned, and I work at CMS and CCSQ in the Quality Measurement and Value-Based Incentives Group. Oh, next slide, sorry. And in my group, we handle the Promoting Interoperability program for eligible hospitals and critical access hospitals, as well as the merit-based incentive payment system, or MIPS track of the quality payment program. So first, I'm going to talk about our proposed disincentives for hospitals. So what we propose to do is for eligible hospitals and critical access hospitals, we would deem that if they were found by OIG to be information blocking, we would determine that they were not a meaningful electronic health record or EHR user. So if OIG made a referral to us in, let's say, 2025, we would determine that that hospital was not a meaningful EHR user in 2025. The way we would apply the disincentive varies by the hospital type. Hospitals, if they're information blocking in 2025, it would be applied to the 2027 payment adjustment that they would receive. And for eligible hospitals, that's a reduction of 75% of the annual market basket increase. For critical access hospitals, it works a little differently. If they were found to be information blocking in 2025, they would receive a reduction in 2025, and then their payments would be reduced from 101% of their reasonable cost to 100%. I will note that if a hospital is already subject to the penalty in 2025, for example, for cause, because they were not a meaningful user, we would not have an additional penalty. There's just one penalty per year. And since we're going, even if OIG makes additional referrals to us, it's all based on the year that OIG refers the referral to us and not the year that the actual information blocking occurred. Next slide, please. Now we're going to turn to eligible clinicians, and our proposal there sort of mirrors our proposal for hospitals. So again, we're saying that a MIPS eligible clinician would not be a meaningful user if they are found to be info blocking. This would affect MIPS eligible clinicians a little differently because we have 4 performance categories, and promoting interoperability performance category is one of those performance categories, and it's worth 25% generally of the entire MIPS score. We just released the physician fee schedule final rule for 2024, and in that rule, we established a payment adjustment threshold of performance threshold, of 75%. And so if a provider got a 0 for promoting interoperability, they would have to be perfect in the 3 other performance categories to earn a 75, and a 75 would mean they would get a neutral payment adjustment. So if they get a 0 for promoting interoperability, it would be impossible based on the performance threshold that we established for them to earn a positive adjustment. So that, and the years would be the same as for eligible hospitals, so that if they were found to be information blocking in 2025, the referral came to us in 2025, and the MIPS eligible clinician would be determined for 2025 not to be a meaningful EHR user, and we would apply the payment adjustment to the 2027 MIPS payment adjustment. So now that concludes my part of this, and for the other CMS programs that are included in this rule, I'm turning it over to Tim Jackson.
Thanks, Elizabeth, and good afternoon, everyone. So next slide, please. My name is Tim Jackson. I'm here to briefly about the Medicare Shared Savings Program, Accountable Care Organizations, or ACOs, and the disincentives that we have in the rule as proposed. So I'll walk through this very briefly, and I think for those that have listened to Elizabeth, you'll see the distinctions between the promoting interoperability for hospitals and MIPS versus the Shared Savings Program pretty clearly. So we propose to revise our regulations establishing disincentives for the accountable care organizations, ACO participants, ACO provider suppliers that engage in information blocking. We are going to screen the ACOs, the participants, provider suppliers for an OIG determination of information blocking and deny the addition of a healthcare provider such as an SSP participant for at least 1 year. In the case of an ACO that is a healthcare provider, we propose to deny the ACO's application to participate in the Shared Savings Program for the upcoming performance year. And for ACOs that are already participating in the program, CMS may terminate the ACO's participation agreement for the upcoming performance year. We're also proposed to restrict the ability of healthcare providers to participate in the Shared Savings Program for at least 1 year. And would result in the healthcare provider not receiving revenue they might have otherwise earned if they had participated in the Shared Savings Program. Finally, we would determine if it would be appropriate for the period to exceed 1 year if OIG had made any subsequent determinations for information blocking. This concludes a summary of our proposals, and I'm going to turn it back over to Alex. Thank you so much.
Great, thank you, Elizabeth and Tim. So just a couple more slides. Next slide. So, you know, as you just heard in these proposals, it is important to clarify, and we discussed this in the rule, that the actual monetary impact resulting from the application of the disincentives that have been proposed may vary across the healthcare providers subject to that disincentive, because these disincentives have been established under applicable federal law. There are other considerations that would go into how the size of that disincentive for any given healthcare provider. For instance, and eligible hospitals, the size of their market basket increase is contingent upon the amount of IPPS payment that they receive. Or as Elizabeth noted, there are many other policy considerations that go into a final MIPS score that would, you know, in addition to this disincentive, impact what your final MIPS result would be that are, you know, not affected by this proposal. In order to, sort of with those caveats in mind, in order to illustrate the potential impact of 2 of these disincentives, we do include some illustrative estimates in the rule. So for eligible hospitals subject to a disincentive under the Promoting Interoperability Program, we looked expected a median disincentive amount across hospitals, again, based on you know, the amount of IPPS payments they receive, of around $400,000, with a range from the very low end, around $30,000, up to $2.4 million at the high end. For eligible clinicians, we also sought to calculate what the monetary equivalent of losing that 25 points could mean for those required to report the Promoting Interoperability Program. This is 2021 data. So of course, as Elizabeth noted, you know, the policies for the program change each year. So, you know, this should be understood as a historical illustration, but based on that data, estimated a median disincentive amount of around $686, with a range from almost 0 for folks who have very little in MIPS to almost $7,000 or around $7,000. And then we also looked at groups, which obviously constitutes a large percentage of the reporting that occurs in MIPS. And for a median group size of 6 clinicians, that 2021 data showed a group disincentive of around $4,000 with a range of about $1,300 for a small group of 2, up to $165,000 for a large group of 241 clinicians. So important to note, of course, that OIG exercises enforcement discretion as they determine what investigations they will pursue based on the claims that they receive. And so not every case referral of information blocking may ultimately be investigated, but we wanted to at least provide some sense of what the value of some of these disincentives can be. Next slide. So finally, the proposed rule includes a request for information. As folks may have noticed, the programs under which we've proposed disincentives would cover a large number of healthcare providers that participate in these programs, but does not cover the complete list of those healthcare providers defined in 45 CFR 171 based on that Public Health Service Act definition. And so the proposed rule requests information from the public on additional appropriate disincentives that HHS could consider in future rulemaking to address some of those other provider types that are not implicated under the proposals in this current rule. And as part of that RFI, we encourage commenters to identify specific healthcare providers that they would suggest HHS establish disincentives for, as well as ideas about the potential disincentives that could be established for those providers using authorities under applicable federal law. And the RFI also requests information about how HHS should potentially prioritize establishing disincentives for those different healthcare providers. Next slide. So here is a link to the ONC webpage on the disincentives rule. You'll find a link to the rule, as well as a couple of fact sheets providing other information there. Want to remind folks again that public comments must be submitted by 11:59 p.m. Eastern Time on January 2nd, 2024, in order to be considered as part of the final rule. And I think with that, next slide. I think with that, we will take questions, and it looks like we already have a number of questions coming through in the chat.
There was one chat question, Alex. People were asking, when will this rule be effective?
Okay. Yeah, so we haven't set any additional effective dates. This would be effective following the publication of the final rule.
There are also a lot of questions, people asking for MIPS eligible clinicians. How, if an individual is found to be information blocking, how that would impact the group. So our proposal right now is that if the group chooses, that TIN chooses to report as a group, if one person in the group is found to be information blocking, the penalty would be applied to the whole group.
Great, thank you. Do you also want to answer this question about how this will work for providers who reweight PI?
We didn't explicitly propose anything, but we're interested in your ideas. We will be looking at all the OIG referrals on a case-by-case basis to determine how to apply the disincentive.
We've got a few raised hands.
Okay.
So perhaps
Yeah, great.
Kiara or Tom, if you could please unmute Lindy Gunderson, and Lindy, you can accept that request and ask your question out loud.
Sure.
Lindy, if you just click your unmute button, you can ask your question now. Okay, perhaps we can move on to Melissa Solis. Melissa, you can unmute your Zoom now and ask your question. Oh, it looks like you put your hand down. How about William Roberts?
It looks like William put his hand down as well.
Sure. Delaney Bounds. How about Scott Hill?
I didn't raise my hand.
Oh.
Sorry.
All right, Kiara or Tom, if you could just lower Scott's hand, please. Kimberly Velasco.
Hi, are you able to hear me?
Yes.
Yep.
I was inquiring about FQHCs specifically. Where and how do they fall into the disincentivized plan? And also, if there isn't a rule yet set up for FQHCs, do we go by the healthcare providers rule? That was it.
So I think, yep, go ahead.
You go ahead, Alex.
No, I was just going to turn it over to you. To the degree FQHCs are healthcare providers participating in the programs where we've established disincentives, then the disincentive proposals would apply to them.
But also, this rule is not meant to encompass all providers, so it is very possible we will do additional rulemaking in the future to establish additions for other kinds of providers. And that includes Medicaid. This rule does not address Medicaid, but we are working with long-term care facilities and other entities. And so there is the possibility of future rulemaking in the future.
Okay, so currently, do we not follow, are we exempt from the rule, or do we just wait for a future?
It would only impact eligible clinicians who are practicing in FQHCs if they
Okay,
participate in MIPS, but if they don't, it doesn't affect them right now. Would not.
okay, thank you so much, Elizabeth.
Mhm.
I have a question here. The HIPAA regulations at 45 CFR 160.103 define a covered entity in part as a healthcare provider who transmits any health information in electronic form in connection with the transaction covered by the subchapter. That section defines a healthcare provider in part as an organization who furnishes bills or is paid for healthcare in the normal course of business, and healthcare in part as the sale or dispensing of a drug, device, equipment, or other item in accordance with a prescription. As it relates to information blocking disincentives, does OIG include in its list of healthcare providers the manufacturers of medical devices that conform to the aforementioned regulations? So again, we'll note that there are certainly probably several definitions or related definitions of healthcare providers in federal regulation. For the purposes of information blocking, we are using the definition in the Public Health Service Act, Section 3000, that was shown on the screen earlier, which I believe does not include manufacturers of medical devices. I will answer another one from Tracy Jenkins. Is there a specified disincentive for SNFs and nursing facilities? So would note that I believe, and Tim, you can correct me here, but there are cases in which a SNF may be a provider or supplier for an ACO, in which case it could be subject to the proposed disincentive under the shared savings program. But this rule does not include a proposal, for instance, under the dedicated SNF payment systems. Is that right, Tim?
Not sure.
Jumped out, but
Oh,
yeah,
we lost
that's
him.
correct, Alex.
Is it possible to go back to the slide that includes all the different types of healthcare providers? Because there seems to be a lot of questions on who's considered a
great.
healthcare provider.
It's close to the beginning. Elizabeth, maybe you want to answer this. If a hospital is found to not be a meaningful user, the clinicians that practice at the hospital would not incur penalties under MIPS. Is that correct?
Yeah, we would consider it separate unless OIG made a specific finding based on and included the MIPS eligible clinicians. But generally that, I don't believe that would happen.
Yeah, an important point there that this is based on the OIG investigation and determinations that OIG would make that the healthcare provider met the definition and that a specific definition, and that they also, their practices met the definition of information blocking to the degree that they proceeded with a referral. But they would specifically refer that hospital for a disincentive, as opposed to if that hospital was the subject of the information blocking investigation. Do we have any more raised hands?
No, not at this time.
Okay, let me my way through the rest of these. Have a question. Is there an appeals process if an organization is found info blocking? We'll just reiterate the note in the presentation that unlike for other actors, the Cures Act does not specify certain appeals procedures for healthcare providers. And so any appeals process would be the process that's available under the authority that the disincentive has been established. And there's some discussion of that in the rule in a few places about how the individual programs believe that would potentially work in their programs. Oh, can you go back to that slide? So I see a question. Sorry, just lost it.
I think there was a question about ambulances.
Gotcha. So about ambulances, I would note that the healthcare provider definition does include an emergency medical services provider. Under the current rule, no disincentive has been proposed that is dedicated specifically to ambulances using an authority under applicable federal law, but would note that that is a line in the healthcare provider definition. Got a question here that I think you flagged also, Elizabeth. Will ONC or CMS report back to OIG on information blocking complaints they receive? And we'll note that, yes, that is part of the current structure. ONC collects complaints of information blocking and provides those to OIG as which OIG can determine whether they would pursue an investigation on. Got a couple questions around corrective action plans. Will providers, hospitals be given the opportunity to develop an action plan to avoid disincentives if found to be info blocking? And is there a corrective action component to be developed as part of this process when an incident of information blocking has resulted with a positive finding? I will note that there are not proposals to that extent now in the proposals for eligible clinicians and hospitals. Elizabeth, not sure if you want to add anything about that.
No, that's good.
I know there are a number of questions here about specific examples and whether or not they're information blocking. Not going to address those today, since that's not quite in the scope for this disincentives rule, but would encourage folks to look at the materials on the ONC website and can also submit questions to ONC. Have a question. Is there any allowance for self-reporting and avoiding a penalty since mistakes happen by accident at times? We'll just refer folks back to the specific definition of information blocking for healthcare providers, which requires that the healthcare provider knows that the practice was unreasonable and likely to interfere with the access, exchange, or use of electronic health information. So important to remember that there's a fairly significant standard for when a healthcare provider has committed information blocking. I think we answered questions about the group treatment. We still have Ariana on for MSSP. I think we have a question. So all providers in that ACO would effectively be kicked out for a year as well.
Hi, Alex. So thanks for that question. I did provide a response in writing,
Oh.
but if an ACO applicant or renewal applicant is itself deemed to be a healthcare provider that has received an OIG information blocking determination, we would deny the ACO's application for participation in the shared savings program. Likewise, if an ACO that is already participating in the program is referred to us as having received an OIG determination of information blocking, we may terminate the ACO's participation agreement for the upcoming performance year. And this is discussed in the proposed rule. Thanks.
Let's see. See a question. What are the disincentives for hospitals participating in ACO REACH? I would note that there is no specific disincentive associated with that model that we've proposed as part of this proposed rule. Of course, to the extent that hospitals would be that some of the other disincentives we've discussed would be applicable, those disincentives could apply to those hospitals if finalized. Let me see. So one question: for the disincentive to be applied, is there an investigation period or resolution option prior to the determination of information blocking? Would refer folks to the OIG rule that includes more detailed discussion of that investigation period. OIG talks about what that may entail, how that may entail receiving information from the target of an investigation, reaching out to that target. All of those would be things that occur prior to the ultimate referral to an appropriate agency to be subject to appropriate disincentives. But once that referral is made, the proposals in this rule would not include, do not currently include an additional period prior to the imposition of that disincentive. Is there a threshold for the number of patients directly impacted by information blocking that would help determine which disincentives should be applied? So two things. We'll note that as part of the anticipated enforcement priorities that OIG would use, that we noted in the rule, they would consider sort of the scale of patient harm as part of whether they proceed with investigation of an information blocking claim. However, once that claim was referred to the appropriate agency, under this proposed rule, there would be no, that healthcare provider would be subject to any of the disincentives we've finalized that are applicable to that healthcare provider. So there wouldn't be an additional choice about which disincentive to apply among disincentives that may be applicable to that healthcare provider under these proposals. Let's just maybe take one or two more. So another question about CMMI. I don't believe there is an attestation for information blocking for the primary care first program. There be any disincentive for this program if there is not attestation? So that is correct that we have not proposed a specific disincentive under the CMMI authority under which that program has been established. But also important to remember that healthcare providers are subject to the information blocking regulations, regardless of whether they may attest in some program that they are not committing information blocking. That may be included as part of some programs as sort of a way to ensure that participants are not interfering with information exchange, but it does not change that those healthcare providers are subject to the regulations. The question separately of whether that participant would be subject to one of the disincentives we proposed here would be based on whether that is applicable to them. But again, the fact that a healthcare provider is subject to these disincentives or is not subject to these disincentives does not mean they're not included in the definition of healthcare providers that are supposed to meet the information blocking regulations. And again, in the future, HHS is exploring additional disincentives that could be imposed using authorities under applicable federal law.
I just want to add something about the OIG investigations. So we would not be applying penalties until after this final rule is effective, but OIG could do their investigations of previous years. We're basing our application of the disincentives based on when CMS would receive that referral from OIG, and it could address instances of information blocking in previous years if that's when OIG determined there was information blocking.
So we have a question: if a provider is guilty under HIPAA regarding patient access to records, I assume they could also be guilty under the IB rules. Correct. Would just note the coordination element. I think I briefly discussed that OIG goes into more detail on in their final rule that the Cures Act provides for, and OIG has stated that it will work with OCR in those cases where there is an information blocking violation that could also be a HIPAA violation, and coordinate around how to resolve those claims.
And it looks like we're at time.
Yep. So we'll just say thanks so much to my CMS colleagues for joining to talk about the rule. And thanks to everyone for joining and all the great questions. We really appreciate all the engagement, and we look forward to seeing folks' comments on the proposal.